Welcome to Roadmap to Residency. Today we are diving into arrhythmias for your board exam preparation. This video focuses on high-yield test-taking strategies, not teaching you every detail about arrhythmias. We will walk through question stems, help you recognize patterns, and show you how to eliminate wrong answers efficiently. For the complete foundational knowledge, please refer to your first aid for the boards or Step Up to Medicine textbook. Let us get started. By the end of this video, you will be able to do 3 things. First, master test-taking strategies for atrial fibrillation, specifically knowing when the question is asking about rate control versus rhythm control. Second, recognize the presentation of life-threatening ventricular arrhythmias in question vignettes and apply the correct advanced cardiac life support algorithms. Third, identify classic bradyarrhythmia presentations, especially complete heart block, that require pacemaker placement. Remember, this is strategy-focused. For content review, use your first aid or Step Up to Medicine. Let us start with atrial fibrillation, specifically the rate versus rhythm decision, which is a common board question. Rate control is your go-to for older patients with minimal symptoms, chronic or persistent atrial fibrillation, and those with multiple comorbidities. First-line agents are beta blockers like metoprolol, with calcium channel blockers like diltiazem as alternatives. Digoxin is reserved for sedentary patients with heart failure. Rhythm control is for younger patients who are symptomatic, those with new onset or paroxysmal atrial fibrillation, and candidates for structural heart disease intervention. Options include cardioversion if onset is less than 48 hours, or the patient is on anticoagulation, and antiarrhythmics like flecainide for structurally normal hearts, or amiodarone for heart failure patients. Now let us review some high-yield buzzword associations that commonly appear on boards. For atrial fibrillation, listen for irregularly irregular rhythm, absent P waves on electrocardiogram, and embolic stroke risk. These are classic descriptors. For ventricular tachycardia, key phrases include wide complex tachycardia, history of structural heart disease, or prior myocardial infarction. When you see wide complex plus heart disease history, think VTAC until proven otherwise. For third-degree heart block, buzzwords are complete atrioventricular dissociation, Canon A waves on jugular venous pressure exam, and syncope. Complete dissociation means the atria and ventricles are beating independently. Let us work through our first case. A 72-year-old woman with hypertension and diabetes presents with palpitations and fatigue for 3 weeks. Her heart rate is 135 beats per minute and irregularly irregular. Blood pressure is 140/90. The electrocardiogram shows absent P waves with a narrow complex irregular rhythm. She is hemodynamically stable. What is the most appropriate initial management? Take a moment to think through this before we break it down together. Let us walk through this case step by step. Step 1. Identify the rhythm. Irregularly irregular plus absent P waves equals atrial fibrillation. This is the classic electrocardiogram description. Narrow complex means the ventricles are conducting normally through the AV node. Step 2. Check stability. The patient is hemodynamically stable with normal blood pressure. There are no signs of acute heart failure, chest pain, or altered mental status. A stable patient means no immediate cardioversion is needed. Step 3. Choose the strategy. She is an older patient with chronic symptoms lasting 3 weeks, so this points to rate control. First line is a beta blocker, like metoprolol, or a calcium channel blocker, like diltiazem. The correct answer is to initiate rate control with metoprolol, or diltiazem. Here is our second case. A 55-year-old man with history of prior myocardial infarction collapses at home. Emergency services find him unresponsive with no pulse. The cardiac monitor shows a wide, complex, regular tachycardia with a rate of 200 beats per minute in a monomorphic pattern. What is the most appropriate immediate intervention? This is a cardiac arrest scenario, so think quickly about what you would do. Let us work through case 2. Step 1. Check for pulse. No pulse means cardiac arrest. This patient needs immediate advanced cardiac life support. Begin chest compressions while preparing the defibrillator. Step 2. Identify the rhythm. Wide complex monomorphic tachycardia in a patient with prior heart attack equals ventricular tachycardia until proven otherwise. Pulseless ventricular tachycardia is a shockable rhythm. The correct answer is immediate defibrillation followed by cardiopulmonary resuscitation. Remember, for pulseless VTach, shock first, then resume compressions. Here are some advanced cardiac life support algorithm pearls for boards. Shockable rhythms include ventricular fibrillation and pulseless ventricular tachycardia. These require immediate defibrillation. After the first shock, give epinephrine every 3 to 5 minutes. After the second shock, consider amiodarone at 300 milligrams. Non-shockable rhythms include asystole and pulseless electrical activity. These are not shockable, so focus on high-quality cardiopulmonary resuscitation and epinephrine. Identify and treat reversible causes using the H's and T's: hypovolemia, hypoxia, hydrogen ion or acidosis, hypo or hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins, and thrombosis. Case 3 involves bradycardia. A 78-year-old man presents after a syncopal episode while walking. He has a history of hypertension and takes amlodipine. Heart rate is 35 beats per minute. Blood pressure is 85/50. The electrocardiogram shows complete atrioventricular dissociation with a regular atrial rate of 80 and a regular ventricular rate of 35. What is the most appropriate next step? Think about what the electrocardiogram is telling you and how sick this patient is. Let us walk through case 3 on complete heart block. Step 1. Identify the block. Complete atrioventricular dissociation means the atria and ventricles are beating independently. The atrial rate is 80, the ventricular rate is 35, and there is no relationship between them. This equals third degree or complete heart block. Step 2. Assess for instability. The signs of instability here are hypotension at 85/50, syncope, and a heart rate of 35. This patient is symptomatic and hemodynamically unstable. The correct answer is transcutaneous pacing, followed by transvenous pacing and permanent pacemaker evaluation. Unstable bradycardia with complete heart block needs emergent pacing. Time for some multiple choice practice. A 65-year-old man with stable atrial fibrillation on metoprolol reports occasional palpitations but denies shortness of breath, chest pain, or syncope. His CHA2DS2 VASC score is 4. What is the most important medication to add to his regimen? A. Digoxin for better rate control. B. Aspirin for stroke prevention. C. Apixaban for anticoagulation. D. Amiodarone for rhythm control. E. Diltiazem for additional rate control. Think about what the question is really testing before looking at the answer. Let us break down why C is the correct answer. A CHA2DS2 VASC score of 4 or more in males, or 3 or more in females, mandates anticoagulation. Direct oral anticoagulants like apixaban are preferred over warfarin. Stroke prevention is the priority in atrial fibrillation management. Why are the others wrong? A is incorrect because digoxin does not prevent strokes and is second line for rate control. B is wrong because aspirin is insufficient for high-risk patients. D is incorrect because rhythm control does not replace the need for anticoagulation. E is wrong because his rate is already controlled. The test-taking pearl here: when you see atrial fibrillation plus a CHA2DS2 VASC score in the question, they are testing anticoagulation decisions. Always prioritize stroke prevention over symptom management. Here are the high-yield pacemaker indications for boards. Always remember, third degree or complete heart block with symptoms like syncope or hemodynamic instability is a class 1 indication for permanent pacing. Second degree Mobitz. Type 2 block often progresses to complete block and typically requires a pacemaker even if the patient is asymptomatic. Symptomatic sinus bradycardia, unresponsive to medication adjustment, also qualifies for pacing. Board questions often test whether to pace versus observe, so know these indications cold. Thank you for watching this Arrhythmias board review. If you found this helpful, please hit that like button and subscribe to our channel for more high-yield board review content. Turn on notifications so you never miss a new video, and share with classmates who are also preparing for boards. For one-on-one tutoring sessions and personalized residency advising, visit roadmaptoresidency.com. Our expert tutors and residency advisors can help you succeed on your board exams and match into your dream program. For deeper content review on arrhythmias, check the cardiology chapters in First Aid, Step Up to Medicine, or your favorite question bank. Good luck on your exams.